Good morning and welcome to Meet the Press. I'm Augustine Monroy, and this morning we're asking a question that shapes millions of American lives on nothing more than a zip code. Does where you live decide whether you actually get to see a doctor? Joining me this morning is a panel that's covered the country coast to coast, from mountains of Utah to the Black Belt of Alabama, by way of California border, to break down how these three states answered that question, three very different ways. I'll start off with my own state, California, where the story isn't about refusing to expand Medicaid. It's about expanding it about as far as any state in the country has, and what happens when the bill comes due. Then we'll turn to Morgan Slade, who's taking us to Utah, a state that put real money behind maternal mental health, to ask why insurance on paper still isn't the same as an appointment on the calendar. And we'll close with Emily Stinson King, bringing us to Alabama, one of 10 states that never expanded Medicaid at all, and what the decision has cost in dollars, in hospitals, and in lives. 3 states, 3 strategies, one question underneath all of it. What does it actually take to turn a policy into a doctor's visit? Let's get into it. I grew up in California, in National City, California, 12 miles from the US border, a mixed status Chicano community where getting sick and getting seen by a professional doctor were 2 different problems. I'm covering California, and specifically, I will examine California's Medi-Cal expansion through that lens. California didn't expand Medicaid under the, didn't just expand Medicaid under the Affordable Care Act. By January 2024, it extended full scope Medi-Cal to income eligible adults, regardless of immigration status, enrolling close to 1.7 million undocumented residents, many from communities like mine, where families have paid into tax-based into the tax base for decades without being allowed to draw from it. Eligibility on paper and access in practice, though, are not the same in promise. Medi-Cal reimbursements sit well below Medicare and private insurance, so providers are harder to find, especially in the border and rural regions that already had the fewest clinics and provider options to begin with. The cost of this expansion layered on top of nearly $1 trillion in federal Medicaid cuts under H.R. 1, the one beautiful, big beautiful bill act. This has driven a Medi-Cal shortfall of more than $12.6 billion, pushing the state rollback to the very coverage it fought to build. An enrollment freeze, dental cuts, and new premium phases throughout 2026 and 2027. My organizing background with the PICO National Network taught me one of its foundational principles. You meet people where they are, not where you want them to be. California met its undocumented community in that reality, a community that has spent years excluded and decades paying into the system it could not draw from, and built full scope medical around it. Now the state is asking the same community to cover the cost of funding that it's shortfall. This community didn't cause and was meant to help. As Chicano scholar Rudy Acuna once said, Mexicans, Chicanos in the United States today are an oppressed people. And though they are citizens, their citizenship is second class at best, exploited and manipulated by those with more power. Now I welcome questions from the panel.
Are you going, Emily?
Sure. Okay, Augustine, if current funding cuts continue, what do you think is going to be the greatest impact on Chicano communities that rely on Medi-Cal, and how do you think those communities are going to respond?
That's a great question. The enrollment freeze is the sharpest cut. it closes the door behind people already in. That's the general line. Dental cuts, new premium hits, people already enrolled that are and are living close on the edge. So I'd expect some more. I'd expect some to drop coverage over a small monthly premium, not because they don't need it, because that's real money. You know, starving families, $30, $80. That's the difference between providing dinner, you know, for the week. You know, as for response, I think it looks like what got this policy passed in the first place, organizing. I'd expect the same infrastructure to show back up at the legislature ahead of the 2026-27 budget cycle.
I like that answer to the question too. And I have a follow-up and a bit of an expansion question that, how should California balance expanding healthcare access while maintaining that financially sustainable means to fund the program? You kind of mentioned this in your opening statement, but what are your ideas on really implementation that California could do right now to help manage some of those problems you addressed?
Money talks, reimbursement first. Medicaid physician fees remain substantially below Medicare pays for the same visit. And that gap is a big part of why providers don't take Medi-Cal patients in the first place. Raise rates in border and rural regions specifically. That's what meeting patients where they're at. That's where, meeting the physicians, where they're at as well. And invest in and what I mean by that is investing in that provider pipeline. Loan forgiveness tied to service in underserved communities. We do it for teachers. We should be doing that for doctors as well. More training slots placed locally. This connects, to Morgan, to your Utah point too. Coverage without a network requirement, it just moves the same problem somewhere else.
No, and on that, using Utah as an example, I think you're exactly right. Having insurance and actually being able to access care are two very different things. So while we're really emphasizing Medicaid expansion, and it's an important step towards improving all kinds of healthcare, but for this purpose, I'm just going to focus on mental health care and specifically for maternal mental health care. But coverage alone doesn't necessarily translate into treatment. So using Utah as a case example, because I think it illustrates this distinction really well, Utah has made significant investments in maternal mental health by expanding Medicaid coverage in 2024 and increasing attention to perinatal mental health services. And those meaningful policy changes, they reflect a genuine commitment to improving outcomes for mothers and families, but they aren't necessarily addressing the meat of the cause. One of the questions I want us to consider is what happens after someone qualifies for Medicaid? Eligibility is only the first step. So in Utah, Medicaid benefits are administered through managed care organizations, and those organizations develop provider networks and make many of the decisions about where members receive services. So for like example, if a managed care network does not include clinicians with specialized training in maternal mental health. So I'm a perinatal mental health therapist, but I specialize in perinatal OCD. And there are many other perinatal mood and anxiety disorders that deserve their own type of specialty. But if those uh, organizations say a mother doesn't technically need those um, specialties, they just keep them in-house and don't get them the actual care that they need. For example, a woman experiencing postpartum OCD or severe postpartum anxiety may require treatment from a clinician whose expertise is in that evidence-based protocol that I do, which is called exposure and response prevention. But the specialist may not be available, which I'm not available to many within their network because that organization says that they treat that disorder even though they don't provide specialized care. Even when specialized providers exist in the community, they may not be considered out of network or referrals may not be approved if the managed care organization determines that services can be provided elsewhere. like an in-network provider, or someone that just says they do broad general perinatal health, they'll go to them first, even though they don't have the specialty. So as a result, many families may face long wait times, receive treatment from clinicians without specialty training, or simply go without appropriate care altogether. So the argument I want to make is that true access requires more than expanding insurance coverage. It also requires policies that ensure beneficiaries can receive timely evidence-based care from clinicians who are appropriately trained to treat the conditions they're experiencing. So expanding eligibility is an important first step, but we also have to think more critically about provider networks, reimbursement, workforce development, and referral pathways. Otherwise, we risk creating a system where people are insured on paper, but still unable to access that specialized care when they need it. Ultimately, I hope to highlight this distinction between expanding eligibility for healthcare and ensuring meaningful access to high quality care. They both exist. And I think they're both related goals that we all face in our respected states. But they're not the same thing. Both are essential if we want Medicaid expansion to achieve its intended impact on all of our populations. And I, you know, with that being said, I think we all have meaningful contributions to this conversation when it comes to what are the things that stand in the way. And so I'd welcome any of your questions that you have about Utah in particular, or just other barriers that stand in the way outside of expansion for Medicaid.
Morgan, that lines up exactly with what I found in California. Coverage and access getting treated like the same thing when they're not. But what I want to push on, the network piece specifically, is the possible, or is the problem that Utah isn't requiring MCOs to include these specialties, or that the specialists don't exist to include, or maybe that they exist, but the network directories list them as available when they're not. Sometimes it's called a ghost network.
Mhm. No, that's a really good question. It's not that those providers don't exist. It's that, you refer, I think, in California to them as MCOs, which we can also refer to them that way. But in Utah specifically, we operate under the prepaid mental health care plan, or PMHPs. These regional organizations are responsible for ensuring their members that they receive medically necessary behavioral health services, typically through their own provider networks or contracted providers. So there's a distinct list. Because PMHPs manage referrals and determine whether medically necessary services are available within their network, their members may not be referred to specialty health organizations if that PMHP determines that appropriate treatment can be delivered by an in-network provider. So I just wanted to give a quick example. Here in Utah, one of those PMHPs is a specialty clinic who says they run a postpartum support group. And if someone goes in who has Medicaid and wants to be referred to us, we are an out-of-network provider, but they will often deny that person specialty care because they say that even though we're an IOP, which an IOP has, we see our clients up to 12 hours a week, they equate that 1 hour support group to enough for that mother seeking care. So they will keep her in-house instead of referring to us. So we have all these different levels of organizational systems that are kind of providing this barrier to people seeking this care because of someone's interpretation of what they need, even though it doesn't meet the criteria for maybe how intense their symptoms are.
Morgan, I have a question, and it might be a little bit off topic. Um, are you aware of Utah's like maternal health outcomes that kind of affect, like, is that a reason, like poor health outcomes that have affected their decision to expand access for maternal health or maternity health? No, maternal mental health. That one's kind of hard.
Fantastic. Yeah, yeah, so currently, I believe so in 2024, Utah had the most concentrated number of women giving birth at the youngest age. So
Okay.
we have a lot of moms and a lot of young moms. So of course, we're going to see an exacerbation of symptoms related to perinatal mood and anxiety disorders just because we have more potential. And so 1 in 5 is our statistic right now. So 1 in 5 mothers in Utah will experience a perinatal mood or anxiety disorder. And so that kind of prompted Utah legislation in 2024 to expand Medicaid from 6 months postpartum to up to a year. But again, we know, or we're talking about this, is that Medicaid expansion doesn't equal
Mhm.
treatment outcomes necessarily. It doesn't
Mhm.
equal care. So in Utah, we run what's called the PRAMS, and
Mhm.
this is a national. Yeah,
Mhm.
you're nodding your head.
Yeah.
Yep, pregnancy
Yeah.
assessment monitoring system.
Mhm.
And what happened, what was kind of cool, University of Utah took that and then created a survey based on it and asked, okay, like, so if Medicaid expansion made more moms eligible, why aren't you seeking care? And they came up with a good list of answers. Some of those Augustine discussed, which was Medicaid reimburse some of the lowest. And so there's not clinicians that
Mhm.
are perinatal mental health specialists that are actively pursuing Medicaid eligibility as a provider. Also, a number one issue for women not seeking care in Utah was they didn't have childcare, adequate childcare, or time because a lot of people are in the workforce. And so again, Medicaid expansion is super important. However, it doesn't necessarily in and by itself translate to people being served for the medical conditions or mental health conditions that they're needing service for.
Yeah. I absolutely agree. Like, just because you have coverage doesn't mean you have adequate care. Would you say that those barriers that you just mentioned are the biggest barriers that Utah sees?
Yeah, and I think even to connect it back to Augustine, something has to be done about insurance reimbursement rates because I think
Hmm.
it creates this unique tension for social workers, especially as we work in the clinical field, that we want to be accessible to those populations that otherwise wouldn't have access and not just serve the wealthy, right?
Hmm.
But we also have to be reimbursed for our work. So it creates this unique tension, um, which creates another barrier, right? Like
Hmm.
if we're not accessible, if mental health providers aren't taking insurance and are just doing cash pay, we're by nature not going to be accessible to those people that we've vowed to serve. So
Hmm.
I do think there has to be something about insurance reimbursement rates. It's a huge barrier. Not only just having an amount of providers in an already scarce network for specializations such as maternal mental health care, but um, other mental health conditions as well.
Yeah, absolutely. And
Morgan,
that,
that's a sobering look at what happens when funding shows up, but the network doesn't follow it.
Say
Now
that one
we're
more time. Oh,
now
say
we're
that
headed
one more time.
south to Alabama, a state that never made the investment Utah did and never expanded Medicaid at all.
yeah.
Emily
So
Stinson King is going to walk us through what a decade of saying no has actually cost in dollars, in hospitals, and in lives.
yeah.
Emily, over to you.
Thank you. Thank you, Augustine. And my topic really correlates strongly with both of yours as well, Morgan, because in 2024, my state did the exact same thing of expanding maternal coverage up to a year after delivery. Um, but we don't know yet. It hasn't been long enough to see if it is working to improve our maternal health outcomes. Um, but especially in our rural communities, um, and even some in our metro communities, that we don't have enough providers. Our mental health provider list is so short. I believe it's one in every 846. We have one mental health provider for every 846 residents. Um, and so when we have a maternity patient that is experiencing mental health issues, it's not the easiest to get her in someplace. And most times she does have to go to our community behavioral health clinic, but their wait time is months. And so by that point, You know, who knows what happens when you have to wait months for mental health care. And so, yeah, Alabama has not expanded Medicaid still. And I want to talk about how it can influence healthcare for an entire population. Um, so, like Augustine said, Alabama is one of only 10 states that has not expanded Medicaid under the Affordable Care Act, which leaves many low-income working adults in the coverage gap, where they earn too much to qualify for Medicaid, but not enough to receive affordable private coverage. And so, an interesting fact is that if every remaining non-expansion state adopted the Medicaid expansion, an estimated 2.7 million uninsured adults would gain coverage, and that would include about 161,000 Alabamians. And I want to emphasize, I know that Medicaid expansion is not a cure-all for Alabama's healthcare challenges at all, but coverage plays a really important role in helping people access preventative care. That's the key, is the preventative care, so they can manage chronic conditions and seek treatment before health problems become health emergencies. And Alabama's healthcare challenges are particularly evident in its rural communities, which is a lot of our communities. Nearly half of all children living in rural Alabama are covered by Medicaid or our CHIP program, which is called All Kids. And approximately half of all babies born in the state are covered by Medicaid. So at the same time, many rural communities face provider shortages and rely on a single hospital to meet the healthcare needs of an entire region. But when insured patients are unable to pay for care, those hospitals absorb a lot of those uncompensated care costs, which places an even bigger financial pressure on these facilities that are already operating on very, very, very thin margins. And another interesting statistic is that 74% of rural hospital closures have occurred in states that have not expanded Medicaid or had done so for less than a year. And when a rural hospital closes, communities lose far more than just a building. They're losing their emergency departments, their maternity services, their specialty care, local jobs, and timely access to health care. So it's really, really important. Also, just throw this on there, is that Alabama ranks 50th in public transportation. So when a rural hospital closes and a woman or a patient, I'm thinking maternal, when a patient now has to drive to the nearest city to go to the hospital, if they don't have a car, they're not going to go. So, but yeah, so I will open it up to the panel for any questions.
Thank you,
I
Emily.
Oh,
If Alabama leaders say non-expansion saves money, but uncompensated care is closing hospitals, is that actually saving anything?
Yeah, that is one of the biggest arguments of why they have not expanded Medicaid, is the cost. But in my opinion, I don't think it's as simple as saying that Alabama is either going to save money or lose money by not expanding Medicaid. Because the state is going to save money in the short term by not expanding Medicaid, of course. But that does not mean that cost just disappears. It is being shifted elsewhere. It is being shifted to hospitals. It is being shifted to local communities, employers. It is the whole other, many other budgets are taking the hit. And so hospitals still have to treat patients who cannot pay. Local communities still have to deal with the effects of hospital closures. Employers will lose productivity when people cannot access their healthcare. And patients will delay their treatment until their conditions become much more serious and much more expensive. And so that is one of the main reasons Alabama leaders have opposed the expansion, is the cost for Alabama. And I'm sure you already know, but under current law, the federal government covers about 90% of the cost, but the state would still be responsible for the remaining 10%. Alabama has a very, very tight budget. So the leaders argue, there is no guarantee that the federal government will always maintain that funding level. And if they don't, Alabama will be put in quite a pinch, and they will be left with a larger financial obligation than they can manage. However, like I said, hospitals are already operating on thin margins as well, and they still have to provide emergency care regardless of a patient's ability to pay. So when a large number of patients are uninsured, hospitals are not getting reimbursed for those services. And so over time, that financial pressure can lead to service cuts or hospital closures. And like I said before, when a rural hospital closes, the impact goes way beyond healthcare. Traveling further for care, losing maternity service, specialist appointments, specialist services, and the community will lose one of its biggest employers, because on average, rural hospitals support about 1 out of every 12 jobs in rural communities within the United States as a whole. So to answer your question, I don't think there is a yes or no answer. I think that the costs are going to exist regardless. It's just a matter of who is going to absorb the cost for it.
Thank you for that response. Morgan?
Yeah, you alluded to this earlier, and like we've been talking about how insurance coverage does not automatically create access to care.
Mhm.
I think I heard you mention in your opening statement that there might already be a provider shortage in Alabama, and I'm wondering, like, how would Alabama address a provider shortage if even more residents, like if you did expand Medicaid, became insured? Like, how would you guys, what would your proposals be for how Alabama address that provider shortage?
Yeah, Alabama has a severe provider shortage, and not just in maternal care. For a lot of things, Alabama has provider shortages. So I think giving more people health insurance doesn't create more doctors, nurses, clinics, etc. And it's a valid concern, especially here in Alabama, because many rural counties already struggle with shortages of providers. So even if thousands of people gained insurance overnight, many of them would still have trouble finding someone to see them, or waiting a significant period of time before getting seen. So in my opinion, my proposal is that Medicaid expansion is not the cure-all solution. I think that it has to be done in tandem with workforce initiative strategies. And that can include expanding physician and NP recruitment to rural communities, increasing loan repayment and scholarship programs for providers who commit to practicing in underserved areas, expanding rural residency programs because physicians are more likely to practice where they complete their residency, increasing reimbursement rates for Medicaid providers to encourage their participation because, as we were talked about before, they get paid significantly less than private insurance reimbursement rates. Continuing to expand telehealth, and then supporting local community centers and rural health clinics. And what's interesting about this is that Alabama already invests in several of these strategies. They have a state physician scholarship and loan repayment programs. They have rural residency initiatives, J-1 visa recruitment for international physicians, and other incentives that are designed to attract providers to underserved communities. The issue is that Alabama does not have a great way of knowing which of the programs are making a difference, because state evaluations have found that many of them are not being consistently tracked or evaluated. So it's hard to determine what is working and what is not to be able to increase those initiatives, and fund them further or expand on them. But I think that would, to answer your question, I think that would have to be done in tandem with Medicaid expansion, because as we've said multiple times, is access, having coverage does not equal access. So
Whether it's saving money is the same tension running underneath this entire panel. California improved eligibility isn't the same as access. Morgan showed us that even a state willing to fund the fix can outrun its own network gaps. And Emily just walked us through what happens when a state never says yes to spending at all. 3 different starting points, same finish line. The coverage on paper only means something if there's a provider, a hospital, and a budget behind it that actually holds. I'm Augustine Monroy, alongside Morgan Slade and Emily Stinson King. Thank you for watching Meet the Press.
Thank you so much.
Thank you.